let me just say a quick thanks to everyone before we get started. Specifically, thanks to Kushal and Marie for the very kind invitation to come and be with you all for this hour. And also to Rafa and Maria for giving us the case and coordinating all the scribing and the VMR overall. And of course, the CP solvers in general for, really changing the entire landscape of medical education on the international level. And it's really phenomenal. They've done a fantastic job. So anyway, I'm just happy to be here and happy to just be a very small part of this. And I'm looking forward to a great case. I told Kushal yesterday, my only hope is that I actually know the name of this organism at the end of this VMR, but I'm hoping we do. So thanks again, Kushal and everybody.
Okay, do we know who is scribing? Gabriela, you're scribing, right?
Yeah, I was just sharing my screen with you.
Awesome. I am really thankful for everyone being here, especially the people who are going to be discussing the case. My name is Maria. I'm from Guatemala, which is a hint to the case. But this happened a while ago when I was in a rural clinic, where it's like we're going to be starting in a rural clinic and then we're going to keep going. So I'll start the case. It's a 22-year-old male who is brought to a rural clinic after he passed out at his job as a farmer. At the clinic, he was awake, alert, and oriented, and had a fever of 39 degrees Celsius and signs of dehydration. He got better after 1 liter of saline and oral rehydration solutions. And when we talked to him, he had told us he had a fever for the past 4 days that hadn't resolved. He was using aspirin for it. He felt tired with general malaise and had pain on his knees and wrists. He also had nausea and mild abdominal pain, but no diarrhea or vomit. And that's the first aliquot.
Kushal, would you like me to go ahead or?
Oh yeah, yeah. So how would you dissect this problem representation? How would you approach this aliquot that we got so far, Dr. Kulkarni?
So let me try to bring out the salient features of the case so far. So first, I was listening closely and I took a sort of jotted down a few notes as it was being presented. So first, the patient is relatively young, 22. I guess depends on your perspective, but for me, that is on the younger side. So that's an important point. We don't know yet about any other past medical history, but we'll see what comes in the second aliquot. A couple of other things that are sort of very important in these kinds of cases is the temporality. If I caught it correctly, and I think that is what is on the screen, is that this is a fever for 4 days. Now, maybe something will be different as we sort of go forward. But if you look at 4 days, if that's correct, that's fairly acute, meaning we think of subacute as a little bit longer, maybe a couple of weeks, and certainly chronic would be much more than that. Sort of classical FUO definitions, fever of unknown origin, if you go back 50 years, were that somebody had a fever for 7 days and they were admitted in the hospital, and despite initial evaluation, nothing turned up. That was sort of the classical definition of FUO. That definition has changed a bit over time because now we can do so many things on the outpatient side as well. And so you don't necessarily need to be admitted in the hospital to sort of officially be an FUO. But I would say if the fever is for 4 days and that's real, then that's fairly acute. A couple of other things that came out to me in this first aliquot. First, is that there was something mentioned, I think the patient is a farmer or lives on a farm or something like, okay, so that may or may not be important. Keep in mind the patient's on a farm, they could have regular infections, then they could also have all the farm associated infections or potentially animal associated infections. So that may or may not be relevant, but I think it's important sort of bullet point. And then finally, I think the only localizing symptom I really heard was pain in the knees and wrists. And then there wasn't really a lot of other things. I didn't hear anything about respiratory symptoms or GI symptoms. Pain in the, let's say, joints, wrists and knees, could be non-specific, meaning there's a lot of infections that, you just get some pain in your joints, and it's not necessarily that the patient has a quote septic arthritis or some sort of, direct pathology in the joints. Could be non-specific. On the other hand, there are certain infections that specifically do give you those kind of joint symptoms. Sort of the classic ones would be things like parvovirus in that area. Zika virus can sometimes do that. Chikungunya is also sort of classic for that as well. And so many of the other arboviral type infections might give those kinds of symptoms. So again, could be pointing us towards something specific, could be relatively non-specific. At this stage, I think it's a little bit early to say for sure. So that's my sort of overall gestalt of this case so far. And then we'll see what comes in the subsequent aliquots.
Yeah, chat has also some wisdom pouring in. People are mentioning IMED mnemonic from CP solvers that would be we think of in any case of inflammation. So inflammation, malignancy, autoimmune, infection, malignancy, autoimmune, drugs, and endocrine. People are mentioning HIV, syphilis, dengue fever, gonococcal, all good thoughts. Do you want to elaborate on any of this, Dr. Kulkarni?
Yeah, I'll just make a couple of points. Dengue is a great idea because of the sort of area we're in. This is in Guatemala, so that is a great thought. HIV can definitely present like this. I mean, if we get some risk factors, I always joke an ID doctor should never miss HIV as a diagnosis. I think that's a great idea. Yeah, depending on the risk factors. I mean, there's certainly no harm in checking. That's a great idea. And then, this is still relatively non-specific. It can be so many things. So maybe I'll sort of refrain from giving a full list, but I love those suggestions that were made in the chat. And I've seen somebody put in the chat Coxiella, which is a great thought. It's it's a causative agent of Q fever, and I'm glad somebody mentioned it. I jotted down anytime I hear animals, or farm, three things come in my mind, sort of reflexively: Bartonella, Brucella, and Q fever. Now, it may not apply in this case, but those are three things that I hear farm, and immediately those three organisms are sort of in my mind somewhere. And so then we'll see what comes out afterwards.
Awesome, I love action. Kushal, should I continue? Yeah, and I specifically love the age, because I was just thinking about it today when I woke up, that I started med school when I was 18, and pretty much everybody was older than me. And when I saw this patient, I was like, whoa, he was younger than me. How did that happen? But okay, I'll give you the aliquot number 2. So a lot of risk factors are coming. Past medical history, he had none. He didn't take any medications or herbal supplements, which I'm just going to point out that looking at a lot of patients who are farmers, they usually take like ibuprofen or things like that, and they don't really mention it. But he said he wasn't taking anything. He didn't have any family history. For his social history, he was from Guatemala, and he lives in a coastal area. He worked as a farmer harvesting sugarcane. He studied until 3rd grade, lives in a house made of wood and metal sheets with no floors, electricity, or water supply. They cook their food in open fire stoves and gather the water from a nearby river and rainwater and store them in containers outside their home. For health-related behaviors, he consumed alcohol on the weekends and had smoked 3 to 4 cigarettes per day for the past 8 years. He has had 4 sexual partners without the use of condoms, and he was not allergic to anything. So I think I'll stop because I know ID loves risk factors.
Yes, we really do love the social history. our procedure, we don't have a lot of procedures in ID. Our procedure is the social history many times. But I love that history, and Maria, thank you. You did a great job giving it. Let me just bring out a couple of important points. So first, now we've established the patient is sexually active, has had 4 partners. And I think you said sometimes without necessarily the use of sort of protection. So that certainly raises the question of sexually transmitted infections. So certainly HIV has to be on our list at this point. Somebody mentioned disseminated gonococcal infection, or they mentioned sort of gonorrhea, and it can certainly present like this. If the patient has a rash or tenosynovitis, we would definitely think about so-called DGI, or disseminated gonococcal infection. I'll just sort of mention, we haven't heard anything about belly pain. We're going to get labs later on. I'll just mention that hepatitis can sometimes present sort of with constitutional or not, non-specific symptoms. And when we expect right upper quadrant pain and maybe nausea, vomiting, things like that, that sort of, rarely it maybe will present some other way. And then we'll see in the labs that transaminases are super high or something like that. So I would just keep in our back pocket, viral hepatitis, Hep B, Hep A. A couple of the things that you brought out. I think something about water from a river, and they're cooking on a stove or something. So I'm going to generalize that to sort of possibility of food or waterborne sort of organisms. And then some other things or can potentially come out. I'd like to specifically bring out leptospirosis as a theoretical possibility because of contaminated water. And then because of contaminated food, again, you can get a lot of different things, but even things like salmonella can present sometimes sort of, kind of non-specifically, maybe just fever and joint pain. Sort of classic typhoid fever includes abdominal pain, rose spots, things like that. I don't know what we're going to see on the exam, but I would bring out salmonella or even some other sort of enteric pathogen might theoretically be possible. You can get a lot of other stuff in contaminated food and water. So I'm not going to sort of give a list of 20 things, but just to point out that may end up being a risk factor as well, which is sort of potentially some foodborne type of illness. And sort of major ones are the ones I mentioned, which were salmonella and leptospirosis. You can, of course, get things like norovirus or adenovirus or astrovirus, but this is the VMR. I think it's going to be something really crazy and not just some run-of-the-mill kind of thing. But those are a couple of things in the social history that sort of came out to me.
Dr. Kulkarni, would you also consider something like melioidosis? I know it's one of my favorite diagnoses, but patient is a farmer, and there have been cases noted in Mexico, Guatemala, and I have seen case reports where people working in rice paddies getting melioidosis. So, and people can present inflammation of all kinds with melioidosis, osteomyelitis, and abscesses. And do you think it fits the illness script, or is kind of stretching too far right now?
I think it could. It sort of didn't jump out to me, but I've been wrong before, so don't want to prematurely exclude anything. So sure, we could toss it on there. Didn't leap out to me, but I definitely think it's possible. And good point about the rice paddy sort of connection, Kushal. And somebody's bringing up the question of tick bites and stuff like that. And so I think even in the first aliquot, we had included some things like dengue and Zika and chikungunya, and all of those kind of would fit, sort of that bucket of vector-borne or mosquito-borne things. Rickettsial illness, I think is still somewhere on the list also right now. I'll just mention that you don't always see a rash with rickettsial illnesses, or even any of these mosquito-borne or tick-borne illnesses. We have in our script, they should have a rash, but they don't always have that. Sometimes they may just have a fever, joint pain, non-specific symptoms. Certainly, if they have the rash, that's helpful, but the absence doesn't entirely rule it out either.
Okay, Maria, you can go ahead.
Awesome. So the next aliquot is going to give you a little bit of the exam, the physical exam. And because we were at a rural clinic, I'm just going to include the labs we had at the moment. So he had a fever of 39 degrees Celsius. His heart rate was 94. His respiratory rate was 16. And his SATs were normal. His blood pressure was normal even before the saline we gave him, and afterwards it was normal. He had generalized malaise. His eye seemed sunken but resolved after fluids. He had his oral mucosa was dry, but that also resolved after fluids. Cardiovascular and pulmonary exam was normal. The abdomen, because he did have some abdominal pain in the history, was non-distended. He had increased bowel sounds. It was soft with mild tenderness to depalpation and had no peritoneal signs and no visceromegaly we could palpate. Neurological, it was normal. And his skin, he seemed dehydrated. And he had like multiple papules, which appeared to be pruriginous based on scratch marks. And we thought they were secondary to mosquito bites. He had no jaundice and adequate capillary refill. I'm just going to mention that the patient had darker skin tone, and that is always a little bit tricky for us to spot like things like the line sign. I don't remember what it's called, or things like the rose spots. We tend to see them in textbooks and people with more white skin tones, and so we didn't see any, but it might have been harder due to his skin color. As we were in a rural clinic, we had limited resources, but we did get a CBC, which showed 6,000 with white blood cell counts of 6,000 with a normal differential, 14 hemoglobin, and 105 platelets. When we saw the platelets, we went back and did a tourniquet test, which was positive. And then stool test, we only had like simple microscopy, which was positive for Entamoeba histolytica, no blood in stools, and we couldn't perform any cultures, and the HIV was negative.
Okay, wonderful, Maria. We just got a wealth of information. So let me try to break it down point by point. So first, and I'm sorry, I didn't actually mention in the first aliquot, you mentioned the patient had passed out. I didn't really comment on that, and we didn't go deep into some syncope schema, but let me just mention, I'm attributing it to volume depletion or dehydration. I mean, if that's not the case, we have a whole other set of issues going on, but I'm going to go with volume depletion for right now. There were some mentions of Faget's sign on the chat. So Faget's sign is you sort of have a fever, and most of the time with fever, you should have concomitant tachycardia because your body's metabolic sort of demands are ramped up. And in this case, the temperature is 39 degrees Celsius, which for folks, sort of Fahrenheit is about 102.2 or, something like that, roughly. And so you'd expect probably a heart rate a little bit higher, especially if the patient's volume depleted. You'd expect some compensatory tachycardia and things like that. So the fact that it's relatively a little bit less, could be some suggestion of Faget's sign. Faget's sign is classically thought to be associated with sort of more intracellular type organisms. So Legionella, typhoid, which was mentioned. And then I think somebody had put in the chat dengue as well. You sort of don't see it as much with things like staph and strep, gram-negative rods, things that give you a classical sepsis picture, which are more sort of extracellular organisms classically. So that's the usual way we sort of think about that. So I think that's an important point. I will say, though, that I take note of it, but I don't necessarily make a slam dunk diagnosis in any direction based on that. I sort of, okay, keep it in my mind, and then, let's sort of see how it plays out. It's like one extra data point. It doesn't make or break a diagnosis. Now, heart, lungs, everything is normal. So really all we have is some non-specific abdominal pain. It's really hard to know exactly what to make of that. Does this mean the syndrome is localizing to the abdomen? Maybe. But on the other hand, a lot of infections can give you non-specific abdominal pain. It doesn't necessarily appear that there's like an intra-abdominal process per se, cholecystitis, appendicitis, diverticulitis, things like it doesn't feel like that. Can you sort of 100% rule that out? Not necessarily, but there's nothing else in the history to sort of suggest those things. There's not nausea, vomiting, things like that. Can I 100% say that's not the case? No, probably not. But they're a little bit lower based on what we have. And then hard to know exactly what this rash is. From what I can tell, it looks like it was attributed to bites of some kind, potentially mosquito bites. Now, if it turns out that is palpable purpura or something, and we're sort of in a totally non-infectious direction, something like vasculitis. I mean, theoretically that is possible. It's relatively acute for that, but I wouldn't exclude the possibility unless we're sort of very confident those are mosquito bites. So I just want to put out there that there is this, I know I'm here to discuss ID, but there's a theoretical possibility of some non-infectious entity. And what comes to mind with belly pain and a pruritic rash on the legs would be something like a small vessel vasculitis. I just want to keep that in the back pocket. Now, if we go with the idea that that's a mosquito bite, and then you combine that with thrombocytopenia, which you've clearly given us, then it certainly raises the possibility of things like dengue, Zika, and chikungunya as well. Those are all things that can still sort of present like this. I wouldn't also take typhoid, sort of off the table as well. And I think you mentioned there was a positive tourniquet test, which is sort of classical for dengue. But theoretically, maybe it's positive in Zika or something else. So I wouldn't 100%, like immediately say, okay, this is dengue. But I think it certainly fits with that, but it could fit with some of the other mosquito-borne illnesses, those two being the sort of main ones. And then we got that the HIV is negative, so I think we can safely take that off the list. So those are my main thoughts. Kushal, any other thoughts? Or if you want to summarize the chat, I hadn't been looking at it.
Yeah, the chat has been saying the same thing. I had few questions. So far you've raised the really good points. The only thing that I was wondering is, do we account for the time course, and do we just rule out any subacute infections like coccidioidomycosis because patient is a farmer with joint pain? Or would you keep that in differentials, or since the symptoms started 4 days ago, would you think it's kind of too acute for coccidioidomycosis? And the other thing I was wondering is, how would you approach case from this point on? Because at this point, it still seems like we can branch out in different directions. So what would you focus on as like the hints, and what would you consider as red herrings and kind of put that on the side right now?
Yeah, thanks, Kushal. So let's talk about Coxie. Can it be Coxie? Maybe. It's a little fast. If we really believe that it's only 4 days, that's a little fast for Coxie. Now, there is such a thing as acute Coxie, but usually it causes more pulmonary type of syndrome. Coxie can also be associated with erythema nodosum in the legs, but this rash, the way it was described, I'm not really feeling erythema nodosum from this rash. So I guess to sort of directly answer the question, which I think it's less likely, but maybe not impossible. I guess I would approach it as I would work up other things. And if nothing came out and the patient's still sick or getting worse, okay, then maybe I need to go back to the beginning and rethink the case. I also haven't heard of Coxie being associated with a positive tourniquet test, but that may be there may be some case report out there that I don't know of. So in terms of next steps, there are a couple of ways to sort of think about this. One, I don't know sort of how much. I realize we're in a rural kind of setting. The patient doesn't really have anything life-threatening, meaning they're hemodynamically stable. If I would, depending on resources I have, I would test for Zika, dengue, and chikungunya, and because with fever, arthralgias, mosquito bites, and thrombocytopenia, I mean, those are my top 3 for sure right now. I would test for those. if you're in a really resource limited setting, the patient is stable, you can watch. I mean, the treatment for those is theoretically supportive care anyway. There's no like specific treatment, that we're going to do. So that's one approach, test for those, watch the patient. If you're in a resource heavy setting, I mean, the patient has fever, belly pain, I think many would end up getting a CT scan in that situation. I realize we don't have that here in this setting potentially, but if I had more resources, I suspect, and this patient came to the ER, my guess is they would end up getting a CT scan anyway. And then the other thing to think about is, I would keep typhoid still potentially on the list. I would at least get a blood culture. And if sort of nothing else turned up, I mean, you can think about empiric ceftriaxone or something like that. It's not wrong. On the other hand, the patient is stable. If they appeared any more sort of unstable, I might empirically treat. And if somebody said, well, I want to give ceftriaxone until the blood cultures come back, I also don't think that's crazy or wrong, or, I mean, we're talking about ceftriaxone, not bank and meropenem or something, so yeah, I think that's reasonable as well.
Gabriel also raised a really important point. What do you think about the stool test positive for antibiotic histolytica? How would you interpret that?
Yeah, very interesting. E histolytica or Entamoeba histolytica can do a couple of things. One, it can cause hemorrhagic colitis, theoretically bloody diarrhea, dysentery. We don't really have any of that on the patient's history. Okay, so that's one. It can also cause, of course, an amoebic liver abscess, which is sort of the other classical thing that it does. Now, the patient's abdominal pain didn't really localize to the right upper quadrant. Hard to know exactly what to make of it. Could just be an incidental finding. I would maybe sort of leave it in our back pocket for right now. If the patient develops bloody diarrhea, okay, then I think that suddenly comes out as a major possibility. On the other hand, if the abdominal pain gets worse, we also don't have Lfts yet, actually. So maybe we'll see the liver functions if something is sort of very crazy there, and we're going to image the abdomen, and we find out there's an abscess there. Okay, well then now suddenly things change again as well. So for me right now, I would keep it in the back because it doesn't really fit the rest of the script. But we've been surprised before. I don't want to ignore it entirely. There is, of course, the sort of very outside possibility that the patient has more than one thing, that they have two infections theoretically. We like to go for Occam's razor. Okay, try to put it all into one specific syndrome. I wouldn't rule out the possibility of two. That seems less likely. It's pretty acute. The odds are lower that the patient suddenly got two new things. But I don't want to be too premature in ruling that out either. Feels less likely, but I would keep that possibility sort of out there.
Would you consider getting serology for strongyloides, considering it can penetrate from the skin, considering he's a farmer? And I've seen a patient presenting with abdominal rash, which is pruritic, and I think it's called larva occurrence. Would you get the stool serology or repeat ONP and stuff like that?
You could. I don't necessarily think it's wrong. I guess a couple of things that feel a little bit weird is the sort of, height of the fever, the kind of joint pains, thrombocytopenia. Can it be? Sure. Feels a little bit less likely for acute strongyloides. I don't want to take it entirely off the table because again, this is a VMR. You don't know what's going to happen, but feels a little bit less likely with that constellation and this situation. But again, we may be surprised. If the patient starts developing diarrhea, then I think we'll see. It could evolve. If the patient develops a new symptom, specifically diarrhea, then I think that we're sort of more into that potential category. I'll also note, this doesn't rule it out, but the patient doesn't have eosinophilia. Now, again, that doesn't like 100% confirm that there's not a parasitic infection. So because if he had it, that would raise the possibility. But the absence doesn't entirely rule it out. So I hope that makes sense. So so I'm just noting that out there. It's kind of like a low procalcitonin. It suggests that maybe there's not an active bacterial infection. It doesn't 100% take it off the table.
Thank you, Dr. Kulkarni. Maria, you can present the next set of questions.
Awesome. So I really like the discussion because we were really resource limited. So we did diagnosis of dengue without like any confirmation. And as you said, we treated him with like supportive care with acetaminophen and oral rehydration solutions. And we gave him like signs of complications or things that he should notice for him to come back. So 5 days later, he came back to us. Yeah, the smile, like, yeah, it wasn't going to end there, of course. So 5 days later, he comes back with persistent fever and jaundice. And we decided to send him to the hospital right away. He said that he didn't feel better with our instructions. The fever had persisted and he started having more abdominal pain and diarrhea with 5 to 6 depositions per day. It was actually very far away from our clinic, so he didn't come right away as we had asked him to. He only came back after his mother noticed he was yellow. So at the hospital, the vital signs, he had a fever of 39, heart rate of 70, blood pressure of 100/50, SpO2 normal, and respiratory rate of 16. The physical exam, he now seems septic with conjunctival and skin jaundice, no petechia. The abdominal palpation showed a liver palpable 2 centimeters under the ribcage and slightly enlarged spleen. Still no peritoneal signs, and they started broad spectrum antibiotics and fluids and got a ton of tests that I'll give you next.
And do you want to, I can discuss now, or do you want to give us the LFTs, or you want to hold them? Okay. All right, hold them. Okay, so now obviously we have some new information. Okay, so first, now we're up to probably about what, 9 to 11 days of fever, something like that, 4 + 5. Okay, so this is clearly persisted, number one. Number two, now the patient is looking more ill. Number three, now the patient has sort of hepatomegaly and jaundice. And actually, before I go any further, Maria, what happened to the rash on the legs?
Rash were the same, so same papules and they scratch marks, but like the papules were non-palpable and nothing had changed on the skin findings except the jaundice.
Okay, great. So now the reason I was asking for the LFTs is because the pattern on LFTs is going to help us a lot here. Okay, so first, if the transaminases are super high, I think we're going to be much more in the bucket of viral hepatitis, Hep A, Hep B, things like that. And what we saw was sort of a prodrome illness to that. So that's what I would think if they're like sky high. So that's one. Two, you mentioned also there's a little bit of splenomegaly. And there's no lymphadenopathy, I think, that you mentioned. But anytime I hear 1 to 2 weeks of fever, liver, spleen, I at least entertain, and I know the patient's pretty sick, but I entertain them things like EBV, CMV, toxoplasmosis, sort of acute mononucleosis type syndromes. I think at least still have to sort of be on the table somewhere. So that's another point. Finally, if the other reason why I'm interested in the pattern on LFTs is if the bilirubin is very, very high, sort of disproportionately high to the transaminases, I definitely think about leptospirosis in those cases. And this story right now is very classical for leptospirosis, potentially. If we get the creatinine back, and I don't know if you gave us I don't know if we have a repeat creatinine, maybe we're going to get it. But if the repeat creatinine is high, then you have the so-called Weil's disease, which is sort of fever, jaundice, renal failure which has been associated with leptospirosis. So I think that is certainly on the table. I don't expect typhoid fever necessarily, or salmonella necessarily, to give liver and spleen involvement. That's not sort of a classic association I have in my head, but I wouldn't, sort of entirely take it off the table. The other thing I would just mention is, I'm thinking about other things that go to, sort of liver and spleen. And, I entertained in my head for a minute histoplasmosis, although this is not really the right geographical area for histo. Now, I'm coming back to Kushal's question about cocci. This would be unusual for cocci without any pulmonary involvement. So I wouldn't maybe entirely take it off, but feels unlikely to me for acute cocci without any pulmonary involvement. But, again, weird things have happened. I want to come back to the original farmer issue. And can this be Q fever? I think that's on the table for acute Q fever, Coxiella. I think it has to still be considered. Can this be sort of more acute form of brucellosis? I wouldn't rule it out. I mean, it's a little fast for brucella, 1 to 2 weeks. Usually brucella is dragging a bit more, 3 weeks, 4 weeks, 5 weeks. But, things can happen. The patient has a clear exposure. He's a farmer. So I would not exclude the possibility of brucella or even Bartonella. Again, they feel a little bit fast for me. It feels more consistent with something like leptospirosis, but I wouldn't take those entirely off the table because the patient has those exposures as well. So that would be the place I would sort of start. Also, we'll have to see the labs and stuff. And depending what's changed with the CBC, and especially I'm very interested in the LFTs, then I think we have to go further. I would still keep in our back pocket a pyogenic liver abscess, depending on the LFT pattern and what we end up seeing on imaging, or this amoebic liver abscess, which is still floating around in the background. We need to sort of keep track of that possibility. Doesn't feel like it. I mean, the other thing that's in the liver doesn't feel like it should be a hydatid cyst. I mean, that doesn't seem right for the Echinococcus. I don't think it should be, but we'll see. I think the labs and potentially next imaging may be quite interesting and will help with the branch point going forward.
Dr. Kulkarni, what do you think about possibility of Katayama fever, considering there usually is a lag between exposure and presentation of the Katayama fever symptoms? I think it's around 2 to 3 weeks. And patient had that rash, which is pruritic, and usually the cercardial dermatitis is very pruritic. Does that fit the illness script here? Do you think he has risk factors for it?
Yeah, great question, Kushal. So just for everyone's, Katayama fever is so-called acute schistosomiasis. And I would say at least on the board exams, now real life is maybe more variable. At least on the board exams, people with Katayama fever or acute schistosomiasis typically have a brisk eosinophilia. Now, if we get the CBC and suddenly he has 40% eosinophils, okay, then I think we got to rethink our entire differential diagnosis. But if that hasn't changed so dramatically, feels, again, a little bit less likely without eosinophilia for something that's making the patient this sick if it's from Katayama fever. So I wouldn't exclude it, but at least the classical presentation usually involves eosinophilia.
Okay, awesome. I'll give you some of the things you mentioned. So the white blood cell count was 3,800 with like a normal differential, no eosinophilia. The hemoglobin was 14 still. The platelets were 90. For BMP, the electrolytes were normal. I don't remember his creatinine level, but I think at most he had like pre-renal acute kidney injury, nothing more than that. His AST was 120, his ALT was 240, his total bilirubin was 5.2 with a direct bilirubin of 4.8, his alk phos was 1500, and some of the right away labs that came back were HIV negative, Hep A, B, C negative, CMV, EBV negative, toxoplasmosis, he had an IgG positive, IgM negative, dengue, IgG positive, but IgM negative, and leptospirosis was negative. And we did like x-rays, they were normal, so no pulmonary findings. And we started with an ultrasound, which showed the splenomegaly and slight liver enlargement, no cysts, and no like acute inflammation of the gallbladder or anything like that. And so the final diagnosis are going to be the stool and blood cultures, which came back with the final diagnosis.
Okay, so a couple things on these labs. So first, the hemogram hasn't changed much. If anything, it's heading towards leukopenia rather than leukocytosis. Doesn't look like there's any eosinophilia. The platelets are a little bit less. It's sort of following the script that we had before. Okay, so let's talk about the LFTs, because that's kind of where the action is happening on this case. So first, the AST and ALT are a little bit elevated. And the bilirubin is, 5.2. And the alk phos is 1500. So when you have such a high alkaline phosphatase, if the bilirubin is concomitantly high, it can suggest obstruction, theoretically. When the alk phos is, sort of very disproportionately high, it can suggest something infiltrating the liver. So you think about sort of patterns of LFTs. So the alk phos is super high. So what can infiltrate the liver theoretically? It can be, even a pyogenic liver abscess, I think is possible. We have this amoebic liver abscess sort of floating around in the background. Now you told us the answer is going to be in the stool and blood cultures. I haven't heard of salmonella causing, sort of a liver abscess, but, maybe it's possible. Maybe this is going to be a run-of-the-mill gram-negative. Like I don't know why E. coli or Klebsiella or something like that, but if it really was, in the sort of stool and blood cultures, I'm trying to think of things that are going to grow in blood cultures, because Brucella, Bartonella, acute fever theoretically don't really grow in blood cultures. And then somebody asked, can it be the entamoeba itself? Maybe, although I guess I haven't heard of it growing in blood cultures. I guess I don't want to entirely rule that out. If the anaerobic bottle maybe grows it, that is certainly suggested. But anyway, when I see such a high alk phos, I think of something sort of occupying the space of the liver. In conjunction with bilirubin, you may think about something obstructing. For a minute, I started thinking about some weird flukes, like Fasciola hepatica or Clonorchis or Opisthorchis or these kind of weird things. Often they have eosinophilia associated with them, but the fact that it doesn't, I wouldn't entirely take that off the table. But again, why would those grow in blood culture? I mean, those are sort of parasites. So if the organism really grew in blood culture, you got to think what's in the blood and what's in the stool that is going to grow on normal blood culture, unless it's some weird auger or something like that. I have to go for more normal organisms, like as I mentioned, salmonella, or some typical gram-negative rod or something like that, because I can't think what else is going to grow in a blood culture. Maybe the entamoeba if it's going to be in the anaerobic bottle, but aside from that, I can't really think if it's going to grow. I mean, I'm trying to think of weird stuff that will grow in normal blood cultures. Candida can grow in a blood culture, but I don't know why this would be that. So I guess that's where I would go. Maria, before I go any further, did the organism grow in a normal blood culture?
Oh my God, that's too much micro for me. But yeah, like regular, like we didn't ask for anything special.
Okay, So then theoretically, it should be a run-of-the-mill gram-negative, or something like that. It shouldn't be something so rare or weird, unless it's going to be some organism I've never heard of. I'm also trying to think of things that might come from the water, or food or something like that. There are some weird things like Aeromonas or Plesiomonas. They can sometimes cause diarrhea. I haven't heard of them causing this liver abscess. I did have a patient once when I was an ID fellow with an organism called Edwardsiella tarda, which grew in normal blood cultures. And it's also one of these waterborne kind of organisms. So there is this category of waterborne things that can theoretically grow in normal blood cultures that might cause a hepatic abscess possibly. And then might grow from stool culture as well. So those are the main ones on that list, are things like Vibrio, Aeromonas, Plesiomonas, Edwardsiella. Those are some of the main ones that grow, that can be in the water and cause diarrhea, and also cause a liver abscess potentially.
Okay, so are you ready for the final diagnosis? Stool and blood cultures came back with Salmonella typhi, and he was treated for it, and 10 days later, he was discharged from the hospital.
So much, Maria. I was having palpitations that what is this organism that is before. But no, that was great, Maria. You did a wonderful job presenting, and Kushal, thank you so much for moderating. So I guess going back to the original presentation of this patient, I guess I want to bring out a couple of concepts here. So first, the patient's presentation was sort of fever and joint pain. And immediately you're not going to think about salmonella in that case. So I just want to show that, remember I mentioned at the very beginning, joint pain can be relatively non-specific. It doesn't necessarily point you to something in the joints. So that's one point. Second point is, see, this patient has a positive tourniquet test, and you don't learn that as association with salmonella. You learn that as association with vector-borne or mosquito-borne illnesses. But see, even that sign itself is not that specific for those entities. I think it's really just the platelets are low, and for whatever reason, maybe the capillaries are a little bit fragile, but it doesn't like cinch a diagnosis. So that's one. Two, as you see, the diarrhea came sort of later in the course. The initial presentation in the first week didn't really involve major abdominal symptoms. The patient had some non-specific abdominal pain at the beginning, but diarrhea didn't really come until later in the illness course. That's a third point. Fourth point is, I think you mentioned, Maria, or that the patient's diarrhea was never bloody. I don't think it was, right? Yeah. So that's important, because we have this list of things in our head that cause, quote, bloody diarrhea or dysentery: Salmonella, Shigella, EHEC, Yersinia, Campylobacter. That's our list, right, for bloody, quote, bloody diarrhea. But if you actually go and look at all patients who have Campylobacter or Yersinia or whatever, it's actually less than 50% of them actually have blood in the stool. So sometimes when I'm rounding, the team will tell me there's no blood in the diarrhea, so we can rule out those things. And I would actually never do that, because if there is blood, it suggests those things. But the absence of blood definitely doesn't rule out those possibilities as well. So I want to bring out that concept as well. And then the final point I'll just make about salmonella is, we mentioned it several times as we were going along. For me, what is slightly unusual is I don't typically think of it as causing hepato and splenomegaly. But I will say salmonella has an unusual association with vascular entities. I don't know, maybe many folks already know this, but if you look at, for example, infected aortic aneurysms, what are the common causes of that? The most common cause is Staph aureus, then some streptococcal species, and then number 3 or number 4 on that list is actually salmonella. So salmonella has a weird kind of vascular tendency or phenomenon, or kind of what is it called when something goes towards something, a tropism. It has a kind of a tropism for vascular. So, the liver and spleen are both part of the reticuloendothelial system. So yeah, I don't know if that sort of played into it at all. I will say I've seen several patients with salmonella. Typically, they don't have liver and splenic enlargement, but the sort of rest of the case fit. Maria, let me ask, on the imaging, did the patient end up having a liver abscess or not really?
No, but we only performed ultrasound. So afterwards, yeah, no CT was done. After the cultures came back, no CT was done, and all of his symptoms resolved. So no further testing was done.
Yeah, I wonder whether if you got in CT, whether the patient would have had some micro abscesses or something like that. I'm just kind of hypothesizing now. I have no way of proving that. But yeah, anyway, those are some major points about salmonella and sort of thinking about the diagnostic autopsy of this case. So let me stop there. Kushal, Maria, are there more questions or anything more I can help clarify?
Yeah, I love the discussion, and I like the autopsy is very important, especially in this case, because it was, at first we were very resource limited, and once we figure out it was salmonella, we never knew if he had salmonella and dengue. There's a lot of case reports on both at the same time, and unfortunately we didn't have dengue serology at the beginning. And later it was IgG positive for dengue, and it's could it have started as dengue and then two infections at once, which is something that we see here a lot because the risk factors are similar for a lot of diseases. So where there's one, there's a lot, and so we weren't really sure about that. And I saw this patient months ago, but it's always in my head because it's what you said, how could have we made the diagnosis quicker, especially in a rural setting. And I think we fell short by thinking it was just dengue and not really investigating further. So I think I really like the discussion and I learned a lot. Thank you so much.
Maria, let's go back to the patient's original presentation. I'm trying to think to myself, okay, I'm in a rural setting. Patient comes with 4 days of fever and joint pain, little bit of belly pain, no diarrhea, looks stable, has a low platelets and has a positive tourniquet sign. I mean, I think you guys made the most reasonable diagnosis with limited resources, which is dengue or one of the other mosquito-borne illnesses. Now, is it always theoretically possible the patient can have occult bacteremia or something like that, as this patient did? That's always a theoretical possibility. But in resource-limited settings, that's very hard to prove. Because you have to get a blood culture, then you need to incubate it. The blood culture needs to be growing. You got to have a micro lab. You got to have a machine. I mean, it's a big thing to get a blood culture. So I'm not even sure I would necessarily call it a missed diagnosis. I think you all made the most sort of reasonable diagnosis with the evidence that you had in front of you at that moment. And there's going to be some fraction of patients who end up having something else, and that's okay. That's sort of how the chips fall sometimes. I don't think there was some drastic error or mistake or anything like that. I think you all made a very reasonable diagnosis, which brings me to sort of one other point, which I wanted to make, which is sort of, I make it to the residents all the time here and fellows as well. It's sort of tangentially related to this case, which is that when a patient shows up to the ER and they look really sick, they look like they have sepsis. The three common places where you can quickly identify whether or not they have an infection is lungs, urine, and skin. Skin, you can clearly see, do they have cellulitis or something like that? Urine, you can get a urinalysis pretty quick. And then lungs, you can get a chest x-ray pretty quick. And so you can sort of rule in one of those infections pretty quick as a potential source of the patient's sepsis. But we have a major gap in ID diagnosis right now, to this day, at every major medical center in the United States. And the major gap is when somebody hits the door and they look really sick, at that moment, we don't know whether the patient has bacteremia or not. You just don't know, especially if they have a primary bacteremia without any clear localizing symptoms like your patient. So for example, sometimes patients may come, they may have Staph aureus bacteremia, they may have meningococcal bacteremia, they may have streptococcal bacteremia, some other gram-negative, floating around in the blood. You don't know the source of it yet, but they have bacteremia and they look pretty sick. So I guess the point I'm trying to bring out is sometimes patients can look very sick. The three most common places you can try to find an infection are skin, urine, and lungs. But if you don't find it there and the patient looks sick, so what we shouldn't do is, sometimes I say this, oh, let's hold antibiotics because we don't know where this infection is coming from. But the problem with that is you may theoretically miss occult bacteremia or primary bacteremia because we have no way of diagnosing it until the blood cultures have been cooking at least for 1 to 2 days. Until that's done, you can't sort of prove that they don't have it. There's no way we can quickly make that diagnosis in ID. So what I tell folks is, if the patient looks really sick, like they have frank sepsis in front of you, but you don't know where it's coming from, get all the cultures, go ahead and give them empiric antibiotics. I'm all for stewardship, but when the patient's really sick and you haven't disproven that they have a primary bacteremia, it's better to just go ahead and cover them until you at least have some time and can get some blood cultures, because it's a major gap in ID. You cannot make that diagnosis immediately in the ER. Now, in your case, the patient looked fine, so it's a little bit different. But I just want to bring out that point for patients who do show up pretty sick to the hospital.
Fantastic case, Maria. Thank you for presenting. Dr. Kulkarni, thank you for teaching us all so much. Does anyone have any questions about the case so far? You can write in the chat and we can discuss those after Rafa does the teaching points. I only had one question. So with this case like this, where you have salmonella bacteremia, would you do a surveillance scan for endovascular infection, or would you just follow up the patient once the treatment is over and do the scan if patient is symptomatic?
Yeah, great question, Kushal. In this case, now let me just say, run-of-the-mill typhoid fever, let's say they had diarrhea, bacteremia, maybe not necessarily. What gives me a little bit of pause in this case is the patient has hepatomegaly, splenomegaly, and an ALK phos of 1500. That feels a little bit unusual to me. And maybe I would go looking in the chest and the belly just to make sure they don't have any evidence of an endovascular infection. Specifically, what I mean is aortitis or some kind of infection of blood vessels. I would make me a little bit nervous because, why is the spleen big and these other things? I mean, it's slightly unusual, not unheard of, but enough to probably make me go looking in this case. But in a typical case, not necessarily.
Thank you, Dr. Kulkarni. Does anyone have any questions? If not, Rafa can do the teaching points. Okay, Rafa, you have the mic.
So first, thank you, Dr. Kulkarni, for taking your time and spending this incredible hour with us. It was really, really incredible. Thank you, Maria. Thank you, Kushal. Thank you, Gabby. Thank you, everyone who joined us today. So we had this young male patient with fever for 4 days, and Dr. Kulkarni reminded us that always important to consider the background of the patient, especially the past medical history, but also occupational exposure. For example, in the side of farming, we could think about other types of organisms such as Bartonella, Brucella, Coxiella that we do not necessarily think about when we're treating other patients. And then we saw that this patient had on the background also joint pain, and we thought about arbovirus type infections like dengue, chikungunya, but also syphilis, virus infections. Also important to remember that no infectious causes of joint pain like crystals, hemorrhage, trauma. And then we saw that on the health-related behavior that this patient had unprotected sex, and we thought about HIV, disseminated gonococcal infection, the differential as well. And then Dr. Kulkarni reminded us that ID and social history health-related behavior is very important because we don't have like many procedures in ID, so it's also great to collect a detailed history. And then we saw that this patient had the phages sign, which is in the side of fever, we expect bradycardia. But then in these patients, if you're not, you could think about phages sign. It's associated with intercellular organisms like Legionella, typhoid, dengue, yellow fever, malaria, babesiosis, but it's that extra data point, not something crucial to the diagnosis. And then we saw that this patient had thrombocytopenia and a positive tourniquet test. According to the CDC, this is a marker of capillary fragility that can be used as a triage tool to differentiate patients with acute gastroenteritis from those with dengue. We saw that this patient had a positive tourniquet test, and that's considered positive when you have 10 or more petechia per 1 square inch. And the arbovirus infection was higher in our differential diagnosis because it's positive in the side of positive tourniquet test, but also the rash that we saw on the physical exam. And then we finally see that this patient had febrile jaundice. So Dr. Kulkarni reminded us to always look at the pattern of the Lfts. So we saw higher AST, ALT, we could think about hepatitis, increased direct bilirubin, we could think about leptospirosis, but also other organisms like malaria, yellow fever, EBV, CMV. Other types of non-infectious cause of febrile jaundice that we could think of is Hodgkin's lymphoma and septic thrombophlebitis. And we saw that this patient had very elevated alk phos, and we thought about hepatic infiltration in biliary tree obstruction, including pyrogenic liver abscess, fasciola, echinococcus, and finally salmonella, which was the diagnosis. So thank you everyone, such a great time, and I hope to see everyone tomorrow near VMR.
Thank you all. Have a great day. Thank you again. Thanks, Kushal. Thanks, Rafa. Thanks, Maria. Awesome job presenting. I had a great time. Thank you, everybody.
Thank you, thank you.
Thank you, Maria, Gabriela, Dr. Kulkarni.
Thanks, everybody. Bye.
Bye.